Good morning, everyone. Um, as you have heard, Charlotte and myself would be presenting this this teaching. It is going to be quite a few slides, so try to be comfortable. At the end of the presentation, we hope that you will have learned a lot of helpful information. So first, let's start off with our learning objectives. Our learning objectives today will be learn iatrogenic effects of some of the commonly prescribed drugs. We will also learn about prescribing cascade and deprescribing. We will also learn about pharmacokinetics and pharmacodynamic properties of some of the drugs. And we will discuss evidence-based tools for working with older adults. Sorry, it was the next slide. Yes, now we're on the same page. And we will also discuss evidence-based tools for working with older adults. And we will focus on high-risk drug classes. Polypharmacy, to start off, polypharmacy is truly a growing concern for the geriatric population. Research shows that nearly 50% of older adults take one or more medications that are not necessary. And there's a strong relationship between inappropriate polypharmacy and negative clinical outcomes. Going on to the next slide, please. We will discuss we first need to discuss what do we mean by a geriatric patient. Geriatric patient is an older adult, an age group that's not precisely defined. Older is actually preferred over than elderly. So we want to refer to these patients as older rather than elderly. 65 years and older is the age often used, but many people do not need geriatric care until much later in life. Old is used to refer to patients that are 85 years of age or older. Next slide, please. Throughout the presentation, there's going to be quite a few questions. The first question is, what is the projected population of older adults in the US by 2050? You can enter the answer directly into the poll, and I will pause for about, I'd say 30 seconds for you to enter your answer into the poll. I think we can go on to the next slide. The answer is 83.7 million. Going on to the next slide, you will see this figure depicts that for age 65 and over, by 2050, over 83 millions will be age 65 and over. And if you look at the bottom graph, you can see that a little over 15% of 65 and over by age 2050. So you can see that there'll be a huge population growth in the coming years. And what that means for polypharmacy is we can expect that this is going to be an ongoing issue that we have to deal with, and it's going to be increasing. Going on to the next slide, please. The population growth is fueled by the baby boomers as they began turning 65 in 2011. By 2050, as we saw, the estimated population of 65 and older is going to be about 83.7 million estimated, and the population is actually going to be greater than 15% of the total population. What we need to keep in mind is many older adults have multiple chronic conditions. And as a result of having multiple chronic conditions, they will also be taking multiple daily drugs, which is referred to polypharmacy. And going on to the next slide, please. We're going to tie in drug iatrogenic effect to polypharmacy. Going on to the next slide. There's going to be another question. Where did the phrase "to do no harm" come from? Please enter the best answer in the poll. It's not a trick question. And I will pause for a few minutes. All right, we can go on to the answer, which is the next slide, please. The answer is "of the epidemics" by Hippocrates. I'm sure most of you got that answer correct. And we can go on to the next question. Iatrogenesis is defined as any noxious, unintended, undesired effect of a drug that occurs at doses used in humans. And it can be doses for prophylaxis, diagnosis, or any type of treatment. An adverse drug reaction is an undesired effect of a drug that either increases toxicity, decreases desired therapeutic effect, or both. Please keep the definition of ADRs in mind as we go through this presentation. Next slide, please. What is depicted here is when multiple drugs are prescribed to a single patient, drug-related harm is very much bound to happen. All the blue areas represent adverse drug reactions. And then the adverse drug events, oh, I'm sorry, take that back. Adverse drug events is all the blue areas. And then adverse drug reactions is only the dark blue. So the adverse drug events encompasses adverse drug reactions. And we'll be focusing heavily on the adverse drug reactions. And then you can see the medication errors, how that encompasses some of the adverse drug events and adverse drug reactions. Going on to the next slide, please. Question 3. Which of the following is a classification of an adverse drug reaction based on the type of reaction? Please enter the best answer in the poll, and I will pause for a few minutes as you think about this question. And let's go ahead and go on to the next slide, please. The answer is all of the above. And we'll go into the explanation in the next slide. Next slide, please. A would be a type of ADR that's dose-related. The severity increases with a dose increase. An example would be if you were to give a patient, let's say, amitriptyline, which is a tricyclic antidepressant, and the way to manage that would be either you decrease the dose or you withdraw the drug. Type B is bizarre. The mechanism is unknown, and an example would be something like anaphylaxis to penicillin, and the management would be withhold or avoid the drug. Type C is chronic or continuous. It relates to both the dose and time. And the way to overcome this is to either reduce the dose or withdraw the drug. Type D for David is delayed and it's time related. An example of this would be tardive dyskinesia, and this unfortunately is difficult to control. And type E is end of dose, and that occurs after a drug is withdrawn. An example of this would be withdrawal symptoms with someone that's perhaps on a benzodiazepine or an opioid. And the way to manage this, one of the ways would be to reintroduce a drug and withdraw the drug slowly. Type F, you can all imagine, stands for failure. An example would be if there was an inadequate dose of antihypertensive drugs such as lisinopril. The way to overcome this would be to increase the dose and consider effects of other drugs that would be taken along with the lisinopril. And then going on to the next slide, please. What is polypharmacy? What is surprising is the term polypharmacy continues to lack a clear universal definition. It's generally described as simultaneous use of multiple drugs per day by a single patient. So the term polypharmacy is most commonly applied when the patient has 5 or more drugs. Throughout the presentation, we're talking about polypharmacy. Just bear in mind, we're just using 5 or more as the most commonly applied term for polypharmacy, but it doesn't mean that if someone is on less than 5 medications, there's no polypharmacy. So keep that in mind. Polypharmacy is also a major problem for older adults, as you can imagine, due to multiple drugs and then increased risk of ADRs. While we're talking about polypharmacy, it is important to note that under prescribing, appropriate drugs should also be avoided. Not all polypharmacy is bad. There's inappropriate polypharmacy and there's appropriate polypharmacy. And next slide, which will be presented by Charlotte. I will mute and let Charlotte take the next slide.
Thank you. So next we are going to talk about a population-based case control study that was conducted in 2010. The study was done to investigate whether polypharmacy increases the risk of hip fracture in older patients. So the study identified 2,328 older patients who had recently been diagnosed with a hip fracture. They also selected randomly 9,312 individuals who did not have a hip fracture to serve as the control group. They found that patients in the group with recent hip fracture were found to be older than the control group. They were predominantly female, and they were more likely to be on 5 or more daily drugs. The study found that the overall odds ratio for patients using 10 or more drugs was 8.42 compared to patients who used either no drugs or only 1 drug per day. So ultimately, the study concluded that patients with polypharmacy were at an 8 times greater risk for hip fracture compared to those only using 1 drug per day or no drugs per day. So that is a quite a bit higher risk. Next slide, please. So next we have another question. And the question is, which of the following are features of inappropriate polypharmacy? And I'll give you just a minute to select your answer or answers. And this is going to be features of inappropriate polypharmacy. Okay, I think we can close that one and move on to the answer. So the correct answer is B and C. So using a drug where there is no evidence-based indication, or the indication has expired, or the dose is unnecessarily high, that would be a feature of inappropriate polypharmacy. Or having a combination of several drugs that can cause serious adverse drug reactions. And next slide. I will hand it back off to Dr. Jackson now.
Thank you. Types of polypharmacy, as you can see, as shown in this slide, the red shows inappropriate pharmacy, and that's going to be on your right. Inappropriate pharmacy would be when there's no evidence-based indication or the dose is unnecessarily high. The other scenario would be the drug fail to achieve therapeutic objectives that they intended. And another example would be the drug is causing serious adverse drug reactions. Appropriate polypharmacy would be all drugs are prescribed for achieving specific therapeutic objectives. The therapeutic objectives are actually being achieved, or there's reasonable chance that they will be achieved in the future. Another scenario would be where the drug therapy has been optimized, the ADRs have been minimized. And another example would be when the patient is motivated and able to take all the drugs as intended. So those are the two types of polypharmacy. We'll be focusing mostly on the inappropriate polypharmacy for the purpose of this presentation. Next slide, please. Polypharmacy risk factors. There's patient factors and provider and system factors. As we all age, our risk for polypharmacy increases. So you can imagine for the geriatric population, as they age, they're taking more drugs, so there's more risk for polypharmacy. Poor self-reported health is also a risk factor for polypharmacy. Multiple chronic conditions, as we have discussed, is a major risk factor for polypharmacy. Declining nutrition and ability to function, which sometimes does come with aging, is also a risk factor. Decreased cognitive capacity, that's a risk factor. Self-medication, OTC, borrowing from friends and family, this is a polypharmacy risk factor because the doctor or the provider might not be aware of these self-medicated drugs that are on board. Use of multiple pharmacies and lower socioeconomic status. The providers or system factors would be multiple prescribers, prescribing potentially inappropriate drugs would be a risk factor. Poor communication between the provider and the patient is a risk factor for polypharmacy. And different electronic medical records also contribute to polypharmacy. Improper and incomplete medrecs contribute to polypharmacy. Lack of continuity between multiple providers and ineffective transitions of care. All these are polypharmacy risk factors. And going on to the next slide, please. Prescribing cascade and deprescribing. Before we go to the next slide, I would like to share with you an example of a prescribing cascade in an elderly woman, which I came across during, that's in a peer-reviewed article. AA is a 71-year-old female with high blood pressure, type 2 diabetes, asthma, hypothyroidism, depression, and osteoarthritis. AA was admitted to the emergency room following a fall. She had a stroke 9 days before the admission. The fall was attributed to gait and balance problems from multiple causes. They thought it was osteoarthritis, drugs, and stroke. Multiple fractures were identified on the X-ray, lumbar spine X-ray. 4 months before this event, the patient's family physician had prescribed amlodipine 2.5 milligrams twice daily to control her blood pressure. 3 weeks later, her cardiologist prescribed two types of diuretics, furosemide 20 milligrams and spironolactone 25 milligrams once a day. These drugs were prescribed because of edema of the lower legs, which had recently developed. 3 more weeks passed and she was prescribed an anticholinergic, Tovias, or the fesoterodine 4 milligrams once daily by her urologist because she was having incontinence. 1 month after this, she complained of dry mouth, and her family physician advised her to stay hydrated and make sure she's taking plenty of fluids. 1 month later, she lost her balance while washing in the bathroom. She fell, knocked her head and back against a bathtub, had several fractures, and she went to the emergency room. When she presented to the emergency room, along with all the other drugs that I mentioned, she was on metformin, fenofibrate, clopidogrel, rabeprazole, levothyroxine, potassium, aripiprazole, citalopram, bupropion, hydroxyzine, ibuprofen, and montelukast. That's in addition to all the other drugs that we mentioned. Let's look closely at this case study to just summarize the sequence of the prescriptions. May, the patient got amlodipine because she had high blood pressure. After she took the amlodipine, she had peripheral edema. So then June, a different provider prescribed furosemide and spironolactone. And then she had urinary incontinence. July, she saw a different provider, and then Tovias was prescribed, or the fesoterodine. Then she experienced dry mouth, and another provider advised her to make sure she stays hydrated. When the patient went to the hospital, a clinical pharmacist, noticing the sequence of the drug prescribing cascade, recommended to the physician to stop the amlodipine and begin lisinopril. Lisinopril was started instead of the amlodipine, which causes peripheral edema. After a few weeks, peripheral edema ceased. So the furosemide and spironolactone were discontinued. After a few weeks, there was no urinary incontinence. So then the Tovias was discontinued. After the Tovias was discontinued, the patient did not have dry mouth anymore. So that case is a good foundation for what we're going to be discussing. Next slide, please. A prescribing cascade occurs in a situation where you have one drug, which we're going to call drug 1. This drug causes an adverse drug effect, which then is misinterpreted as a new medical condition. As a result, drug 2 is now being prescribed. Unfortunately, drug 2 has an adverse drug effect, which then can be misinterpreted as a new medical condition, and a new drug can be prescribed. So this prescribing cascade, I only show 2 drugs on there, but there can be several drugs, as we saw. Like in this scenario of AA, there were 4 drugs prescribed, just as a result of one drug being prescribed. Going on to the next slide, please. So what can we do about the prescribing cascade? Like the clinical pharmacist in the emergency, in the hospital, discovered the prescribing cascade, we should be looking for these. And what we would do is deprescribe. Deprescribing means you either taper, you stop, or discontinue the drug. This reduces polypharmacy and improves outcomes. Like in our scenario, the patient had multiple drugs, and actually all she needed was one drug. She was taking drugs that she did not actually need. Comprehensive medication reviews, as we saw, and risk assessment can be used to identify ADRs due to polypharmacy. And to reduce inappropriate polypharmacy, deprescribing can be utilized. Next slide, please. These are some of the reasons for deprescribing. The first thing is you want to review all drugs that are being taken. So you want to look at the OTC, you want to be looking at medications borrowed from family and friends. You want to look at any other treatments that are not in the books. The first question is, has the drug been discontinued, substituted, or dose frequency changed? That will need to be assessed. Is a new drug that's now being prescribed, is it to address an adverse event from a previously prescribed drug? The next question is the initial drug that led to the cascade needed, to the prescribing cascade in the first place? Is that needed? And then the last question is, what are the benefits versus risks of continuing the drug that led to the prescribing cascade? So those are some of the ways we can use deprescribing to avoid polypharmacy, inappropriate polypharmacy. Next slide, please. Now we're going to move on to pharmacokinetics and pharmacodynamics properties. And going on to the next slide, we're going to start with a question. Which of these refer to the study of the time course of a drug, absorption, distribution, metabolism, and excretion? Is it pharmacodynamics? Is it drug concentration? Is it pharmacokinetics? Is it kinetic homogeneity? I will pause for a few moments, for a few seconds, for you to get the answer, and if you can enter the answer into the poll, that would be wonderful. Next slide, please. The answer is pharmacokinetics. The way to remember this is use the term ADME, that's ADME. That would be the absorption, distribution, metabolism, and excretion. That is a definition of pharmacokinetics. What we need to keep in mind is pharmacodynamics and pharmacokinetics of drugs are actually altered by aging. And pharmacodynamics is what a drug does to the body. And we will see the concept in slides later on. And next slide, please. This figure depicts pharmacokinetics, which is in green. You can see the absorption. If a drug is taken by mouth, it has to be absorbed. There's distribution into the tissues. There's metabolism, and there is excretion, how the drug will get out of your system. Pharmacodynamics is simply the relationship between the drug concentration at the site of action and the resulting effect. That includes the time course and intensity of therapeutic and adverse effects. And that is shown in red. So as you can see, I know that the figure is trying to depict the kinetics and pharmacodynamics, but if you follow the green and the red, that should help to explain. Next slide, please. We have another question. For a drug with a narrow therapeutic index, the plasma drug concentration required for therapeutic effects is close to the concentration that produces drug toxic effects. Is this true or is this false? I will pause for a few minutes, waiting for you to put the answer into the poll, please. Next slide, please. The answer is true. An example would be digoxin or warfarin. For a drug with narrow therapeutic index, the plasma concentration is required for therapeutic effects is near the concentration that produces the toxic effects. And that's why the dose of such a drug must be very carefully tailored for the patient. Next slide, please. We will go to question number 7. An example of a situation that would not be optimal to initiate therapeutic drug concentration monitoring with plasma drug concentration would be one in which A, a wide variation in plasma drug concentration is achieved in different patients given a standard drug dose. B, the toxic plasma concentration is many times the therapeutic concentration range. C, the correlation between a drug's plasma concentration and therapeutic response is good. D, none of the above. Please submit the best answer in the poll. And I will pause while we wait for you to complete this question. I presume everyone's finished with question 7. We can go on to the next slide, please. So the answer is B. The toxic plasma concentration is many times the therapeutic concentration range. A is incorrect because that would be a good reason for therapeutic drug level monitoring. That was a trick question because we put a not be optimal. We use the word not in the question. So hopefully you caught that. C is incorrect because therapeutic monitoring would be useful in that scenario. Next question, please. Which of these cause variability in drug plasma concentrations after the same drug is given to different patients? Is it A, drug excretion rate, or is it B, half-life elimination? I will pause, giving you a chance to put your answer in the poll. Next slide, please. The answer is A and B. An example would be nitrofurantoin. In this drug, you want to consider the renal function. If a patient has renal function impairment and they're also elderly, so you also want to consider the age. The half-life elimination will be up to 60 minutes. But if the patient is a geriatric patient or an older patient, the half-life is prolonged. So it's going to be much greater than 60 minutes. And the drug is excreted in the urine. So again, renal function impaired, this will cause accumulation in the serum. This is a drug you want to avoid in adults with creatinine clearance less than 30 mL per minute, because this drug will not reach therapeutic concentrations in the urine. And in fact, it has increased risk of toxicity. So this is a drug we want to always be aware of the creatinine clearance of the kidney function. Next slide, please. Half-life elimination is another concept. This is the time necessary for the concentration of a drug in the plasma to decrease by half. T1/2 is just generally what is used to indicate half-life of a drug. Different drugs have different half-lives. An example would be in phenytoin. Small dose increases may actually increase the half-life and produce very substantial increase in serum levels. Older adults, we have to keep in mind, older adults have reduced clearance of highly protein-bound drugs. There's wide interpatient variability in phenytoin serum levels with equivalent doses. So this is a drug, again, that must be carefully monitored, especially in the elderly. Next slide, please. Question number 9. The amount of drug per unit of volume is defined as is it volume of distribution, B, concentration, C, the rate, D, is it all of the above? I will pause. Okay, we can now go on to the next slide. The answer is concentration. So what you see depicted in this figure here is if you take a drug, let's say it's powder, and you put it in a bowl of water, as you add the drug to the water, the concentration is going to increase. So volume of distribution is going to be the amount of drug divided by concentration in the plasma. And volume of distribution is also an indicator of the extent of drug distribution into the body, fluids, and tissues. Concentration is simply the amount of drug in a given volume, such as milligram per liter. Going on to the next slide, please. Evidence-based tools for working with older adults. Since we have been discussing polypharmacy throughout the presentation, now we would like to present some tools for working with older adults to help prevent polypharmacy. And next slide, please. We will begin with a question. Hopefully you're not getting tired of these questions. It's question number 10. Which of these tools can a patient use to manage their at-home medications, vitamins, and supplements? Is it the BS criteria? Is it stop-start criteria? Is it the National Institute of Aging Medication Tracking Worksheet? Or is it none of the above? I will pause for a few seconds for you to enter the answer into the poll, please. And we can move on to the next slide. Thank you. The answer, as you may all have guessed, is the National Institute of Aging Medication Tracking worksheet. Next slide, please. The BS criteria is an evidence-based tool. This is a tool for providers to help in making decisions for older adults to improve medication prescribing. And the BS criteria was created by American Geriatric Society, and it gets updated frequently to keep up with changing prescribing practices. Next slide, please. The stop-start criteria, these are provider tools similar to BS criteria, but they were developed to fill some of the gaps that are not included in the BS criteria. Some examples would be drug-drug interactions, drug class prescription duplication, and omission errors. Next slide, please. This is an example of a National Institute of Aging medication tracking worksheet. It's a useful tool, can be a useful tool for patients. It can help with medication therapy management. There's a link on this slide if you would like to download this tracking worksheet for your patients. You're welcome to do so. And as you can see, it has the name of the drug, what the drug is for, date started, the doctor. What I like about this one, it does have the color and shape. And then it has a dose and instructions. Next slide, please. We will be discussing high-risk drugs because polypharmacy is often seen, and a lot of patients that have polypharmacy, there's a good number of them that are on high-risk drugs. And we can move on to the next slide. These are some of the high-risk drug classes, and we are not going to go through each and every one of these, but I just wanted to highlight the tricyclic antidepressants, the master relaxants, the benzos, the non-benzodiazepine hypnotics, as ones that we will see later on, and the alpha blockers. Moving on to the next slide. Which of the following drug classes increases chances of fall in older patients? A, is it a benzodiazepine? B, is it an opioid? C, is it a tricyclic antidepressant? D, is it all of the above? I will pause and let you answer the question. We can move on to the next slide, please. All of the above is the answer. Benzodiazepines, opioids, tricyclic antidepressants, all of these do cause can cause falls in older patients. Next slide, please. What we see here is a benzodiazepine. This slide is, I'm going to attempt to bring some of the concepts that we've been talking about, the kinetics and pharmacodynamics. I'm going to try and bring them all together. So bear with me as I try to bring these concepts. You have a patient that has anxiety or sleep disorder, and the prescriber prescribes alprazolam. The patient takes the alprazolam. The half-life elimination of the geriatric patient or the older patient is going to be 16 hours. If they're obese, it's going to be 22 hours. Compare that with someone who's not a geriatric patient, that would be 11 hours. So if they're older and they're obese, essentially the half-life is at least doubled. The pharmacodynamics of this drug is it's a GABA aminobutyric acid modulating agent that results in CNS, central nervous system, depressing effects. The reasons to deprescribe this drug in an older adult would be, for an older adult, they have increased benzodiazepine sensitivity. They have decreased metabolism of this drug. And as a result, they have an increased risk of falls by taking alprazolam. So this is a drug you want to narrowly tailor to the patient and make sure that the dose and other drugs on board are appropriate. Going on to the next slide. Again, this is a scenario of sedative hypnotics, and I will attempt to bring all the concepts together. You have a patient that has insomnia. The prescriber is prescribing zolpidem. The half-life for an older adult is about 3 to 3.5 hours. If they have liver cirrhosis, that half-life is gone up to 10 hours. If you compare to someone who's not a geriatric patient, they have about 2.5 hours, about an hour less of half-life elimination. The pharmacodynamics of a benzodiazepine and non-benzo, the pharmacodynamics is that it's a benzo receptor and non-benzo receptor agonist. It has sedative and anti-anxiolytic effects. The reasons to deprescribe this drug would be similar to those that we discussed for the scenario of the benzodiazepine in the previous slide. The patient would be at risk of delirium, they'd be at risk of falls, and of course, fractures. So again, this is a drug that if the patient is going to receive it, you want to monitor this drug. Next slide, please. Opioids. You have a patient that has pain. Let's assume it's acute or chronic, and they're on fentanyl. The older adult has a half-life that's going to be greater than 27 hours. That would be compared to an adult who's not a geriatric patient, which takes about 20 to 27 hours, which is already a really long half-life. So if you have an older adult, you've essentially prolonged that half-life due to reduced clearance. The pharmacodynamics of this drug is it will act on the mu, delta, and kappa opioid receptors. It can lead to neurotransmitter release, neurotransmitter release inhibition, resulting in analgesia. The reasons to deprescribe this drug would be CNS depressing effects, sedation, lowered respiratory rate, increased risk of fall. So again, this is a drug that should be narrowly tailored for the patient and monitored. The next slide, please. Which opioid receptor has the greatest likelihood of affecting respiratory function? Is it the mu receptor, A? Is it B, kappa receptor? Is it C, delta receptor? Is it D, all of the above? I will pause for a moment and let you enter the answer in the poll. We can go on to the next slide. The answer is the mu receptor. And going on to the next slide, please. This slide depicts opioid receptor types. It might be hard to see, but as you can see, the respiratory function is affected by the mu receptor, and once that receptor is activated, that can cause a decrease respiratory function. The GI tract, you have the mu and the kappa receptors, which decrease the transit. That means a patient can have constipation. The sedation is affected by the mu and the kappa receptor, so the sedation will be increased by an opioid drug. And we can go on to the next slide. Selective serotonin reuptake inhibitors, the SSRIs. Let's assume you have a patient that has depression and you prescribe citalopram. Citalopram half-life in an elderly would be about 30 to 65 hours. Compare that with a patient that's not elderly. That would be 24 to 48 hours. And there's a note there that the maximum dose is 20 milligrams per day is recommended in this population because of the risk of QT prolongation. So what are the pharmacodynamics of this drug? There's increased concentration of serotonin in the synaptic cleft, and there's downregulation of receptors resulting in disinhibited neuron. What would be the reason for deprescribing this drug? One of the reasons would be increased risk of falls, sedation, increased anticholinergic effects, and of note, paroxetine has strong sedating and anticholinergic properties compared to citalopram and some other drugs in this class. So that is one that has to be closely monitored. And if someone is on paroxetine, you might want to consider switching to a drug that has less sedation and anticholinergic properties. Next slide, please. TCAs, tricyclic antidepressants. Let's imagine you have a patient that has depression or insomnia and you prescribe nortriptyline. The half-life elimination in a geriatric patient can be anywhere from 24 to 80 hours. If you compare that to an adult, who's not a geriatric patient, 14 to 50 hours. So a huge difference in terms of half-life elimination. This drug increases serotonin and or norepinephrine concentrations in the synaptic cleft, and this drug does cause sedation. The reason to deprescribe this drug would be risk of falls. There's anticholinergic effects, there's sedation, and there's orthostatic hypotension. Going on to the next slide, please. This slide is illustrating the SSRIs and TCAs mechanism of action. The TCA blocks the SART shown in red, and the net, which results in increased serotonin and norepinephrine in synaptic cleft. The SSRIs blocks the SART, resulting in increased serotonin in synaptic cleft. Receptor downregulation occurs in 4 to 6 weeks. And I should have mentioned that the net is actually representing norepinephrine transporter, and the SAT stands for serotonin transporter. So that's what that figure is depicting. Next slide, please. This chart is a comparison of SSRIs and TCAs, and this highlights, well, the potency. Let's talk about the potency. So the measure of a drug activity is expressed in terms of the amount required to produce a defined effect. The lower the number on this chart, the more potent the drug is, and the potential and it's potentially greater the magnitude of the effect. So if you are to take doxepin and looking at the the M or the muscarinic receptor, we have 83.3, and if you were to compare that with duloxetine, which is right below that, is 3,000. So doxepin would have strong anticholinergic effects compared to duloxetine. And then if we were to compare fluoxetine with paroxetine, fluoxetine has, let's see here, looking at H1, fluoxetine is 6250. And if you compare it with, let's say, amoxapine, which is 25, you can see the amoxapine has higher sedating properties. So this chart is just highlighting the differences in terms of the anticholinergic effects, sedation, and serotonin norepinephrine receptor adrenergic effects. Next slide, please. Muscle relaxants. Let's say you have a patient that has skeletal muscle pain and cyclobenzaprine is prescribed. The half-life elimination for an older adult is about 50 hours if they're getting the extended release. And if it's not a geriatric patient, is 32 hours. So you can see there's a huge difference in the half-life elimination. And the reason to deprescribe this drug would be the anticholinergic side effects. There's also increased sedation, and there's increased accumulation in older patients. Next slide, please. How are we doing with time? Angela?
As far as I can tell, we're trucking right along.
Okay.
Charlotte, do you feel Charlotte would be a better judge given the content that you have to move through?
Yes, Elizabeth, I think we're making good time. It's 11:05 right now, so
okay.
I'm
All
feeling
right.
good about this piece.
You let us know if you want a break, if your voice is giving out, if you need a break. I can always hum a few bars.
Okay, I will defer that to the audience. And I'll move on to antipsychotics. Let's say you have a patient that has agitation and they are prescribed olanzapine. The half-life elimination of olanzapine for an elderly patient would be 45 hours. And for a patient that's not elderly, that would be 30 hours. So you can see almost 15 hours that we are talking about. The pharmacodynamics would be depending on the agent, and of course, if there's multiple agents on board, there's cumulative effects. The reason to deprescribe would be increased risk of stroke, greater risk of cognitive decline and mortality in patients with dementia. So that would be some of the reasons to deprescribe. Next slide, please. BPH and cardiovascular agents. Let's say you have a patient that has benign prostatic hyperplasia and you prescribe terazosin. The elderly patient, let's say they're over 70, their half-life is 14 hours compared to someone who's not elderly, that's 12 hours. This difference is subtle, but patient-specific factors and polypharmacy may alter the elimination. So as we go through these drugs, just keep in mind, usually the patient is not just taking one of these drugs. They have other drugs on board. So there's also other factors playing in effect, and some of these side effects can become cumulative. The pharmacodynamics is postsynaptic alpha-1 inhibition resulting in decreased blood pressure and relaxed smooth muscle of bladder neck. The reason to deprescribe this drug would be this drug does cause, or the drug class does cause, orthostatic hypotension. So there's increased risk of falls, and there's increased risk as a result of fractures. This is not recommended for use as an antihypertensive drug in the elderly. Next slide, please. Now we're going to move on to Alzheimer's supportive agents. Let's say you have a patient that has Alzheimer's behavioral symptoms and they're agitated, anxiety, they have aggression, and all these drugs, benzodiazepine is prescribed, zolpidem is prescribed, olanzapine is prescribed. So you have now these three drugs being prescribed. Keep in mind, benzodiazepine, the half-life now, you're talking about 16 hours. The zolpidem, we are talking about 3.5 hours. The olanzapine, we are talking about 45 hours half-life. And the pharmacodynamics is also going to depend on the drug. And these drugs act centrally within the brain. The reason to deprescribe in this scenario is there's anticholinergic effects of multiple drugs. There's going to be increased risk of falls. There's also going to be increased sedation. Again, increased risk of fall as a result. And olanzapine, as we discussed before, has an increased risk of stroke. And there is greater rate of cognitive decline and mortality in patients with dementia. Next slide, please. Discussing changes in pharmacokinetics and pharmacodynamics in geriatric population. This is kind of important as we discuss polypharmacy in the geriatric population. The reason is, as we age, there's increase in body fat and decreased total body water. What does that mean? That means that this will impact the volume of distribution and the half-life of drugs. So all, the volume of distribution and the half-life of drugs that we've been talking about, there will be an impact. There's also decreased liver mass and perfusion. That means that there's going to be decreased drug clearance and increased half-life of drugs. There's also going to be decreased kidney mass, and the number of glomerulus is also going to be decreased. So as a result, there's going to be decreased clearance and increased half-life of drugs. These are all very important considerations when prescribing medications to the elderly. And these are considerations that we should always keep in mind when prescribing any drug to the elderly. Next slide, please. Okay, just go ahead.
Oh, I'll take it away for question number 13. We're going to be testing your guys' medicinal chemistry memory. Which of the following drugs is lipophilic, meaning that it likes fat, oil, and lipids? So we have lithium, diazepam, ethanol, or all of the above?
Hi, it's Angela, and I just wanted to make you both aware that we can show the results of the polls if you're interested in knowing how many folks are hitting the mark or coming close. That's a feature that we can provide you with. Just let us know.
Would you like us to know the results right now after this question?
I think we're doing okay on time, so I'd be happy to see.
Sounds good.
See how
Okay.
everyone's weighing in. All right, I think that should be enough time. Okay, oh, we're pretty split across the board. So it looks like lithium and diazepam are tied, each at 30%. So those are in the lead. So let's go to the next slide. Yep, so 30% of you correct. Diazepam is lipophilic. So if you think about lithium and ethanol, lithium is that small cation. So both of them are hydrophilic, meaning they like water. Next slide. Question number 14. This is going to hark back to a couple slides ago. So as a person ages, they have increased fat stores and decreased body water. Which of the following drugs would stay in the body for longer due to these physiological changes? So increased fat stores and decreased body water. Which one's going to stick around longer? Give you about 20 more seconds.
I feel like I should be humming the Jeopardy tune, and everybody should be putting their answers in the form of a question. What is an ode to Alex Trebek?
Yes.
Kelly, why don't you go ahead and show that answer?
Yes. I think that's a good amount of time. Okay, so diazepam is in the lead again. Let's go to the next slide and see. Yes, that is correct. Great, you guys are right on the money. We can go to the next slide. So next we're going to pivot a little bit and talk about STAR measures. So the Centers for Medicare and Medicaid Services, or CMS, has developed this STAR rating system. They use it to measure both the performance of individual health plans and also measure member experience. These STAR ratings are given on a scale of 1 to 5, and obviously 5 is the best rating, and it's what health plans are striving for. Things that CMS takes into account when they're giving these ratings include how plans are managing long-term conditions, what type of, or like what level of customer service they're providing. And then they also factor in feedback from members in the form of their experience and also complaints. Next slide, please.
Okay, thank you. Provider communication challenges is one concept that we wanted to discuss before we ended this presentation. Because there's more heterogeneity among geriatric patients as compared to younger people due to a wide range of life experiences, cultural backgrounds, perception of illness. This is an important concept to keep in mind. We should also keep in mind that the aging process in patients can significantly hinder communications with provider, and this might be due to sensory loss, decline in memory and recall, slowing of information processing. Next slide, please. So what are some of the helpful communication tips for providers? Allow extra time for older patients. Make sure the patient feels listened to. Write down instructions and simplify information. Use visuals such as charts, pictures, or models. Summarize most important points of conversation with the patient. And with that, this is the end of our presentation, but we have questions and answer. We have plenty of time. So opening up to the audience to ask the questions, feedback.
Well, doctors, we have quite a few questions from one of our our area experts, content
Okay.
experts. It's not
All
just
right.
Michael Knower, it's Dr. Michael Knower. So these are going to be really meaty for you all, and we will do our best as lay people to keep up. But it could be that at some point we need to put you all together to have kind of a debriefing session. Dr. Knower asks his first question regarding question number 4. And I do not have the slides in front of me, so I'm going to rely on somebody to bring up question number 4. Kelly, is that something you can do for us? Can you go back through the slides to the beginning? So Dr. Knower's question is, have you ever tried talking to a 75, hang on. Okay, sorry. When Kelly brought up the question, it popped the chat box out. Have you ever tried talking to a 75-year-old with stage 4 NSCC out of taking his atorvastatin? When the response you get is, who are you to tell me? My cardiologist tells me I need to take it because my LDL is 150. If I stop taking it, I'll have a heart attack. So Dr. Knower is going to get us into some of those real life situations and responses that you all might be able to give us the verbiage for. What would you say in this situation?
Well, that's a really good question. And I can certainly understand being in that situation. I would, going back to the last slides, maybe summarize the information for the patient to read later. Try to use pictures or just make sure I have the patient, some information for the patient to read later and digest the information. But I certainly, that's a really good question. And, you know, try your best. It might not always work because you can't force somebody to do something they don't want to do, but at least you've done your best.
And I bet as pharmacists, you get some of this resistance from time to time. And what that tells me is that, yes, the doctors involved in care need to be having more dialogue so that they know what everybody's prescribing and they can hear the patient's concerns and fears directly. Okay, so here's another one.
Oh, I might add to that one if that's okay. Well, one, I think we often run into the scenario of trying to talk patients into taking statins. So I like seeing it posed this way. Just in general, I think we always have to consider the risk versus benefit. As Elizabeth touched in towards the beginning of the presentation, not all polypharmacy is inappropriate polypharmacy. And there are scenarios where a patient may be on 5-10 medications, but if they're all being prescribed appropriately and they all have a intentional indication, then it becomes a judgment call.
Mm-hmm. Yes, I'd agree with that.
A lot of judgment calls
out
there happening in the moment. You do the best you can, thinking on your feet. Yeah. Okay. Shauna McDonough, sorry, Shauna, if I mispronounced. Shauna asks, my experience is that even with all this information out there, MDs continue to prescribe medication that causes adverse effects. What do you recommend a medical social worker do to assist patients when this happens? You know, we've got a We've got a social worker that might need to flag a doc, and maybe that doc doesn't want to hear this from a social worker. And maybe Dr. Noer can chime in too and give some of his expertise. So, doctors, how would you help this social worker?
I think I want to refer that one to Dr. Noor.
Kelly, can we unmute Dr. Noer? Is it possible to unmute one participant at a time? Let us know. But in the meantime, Shauna, I feel for you. I hear what you're saying is that there does tend to be the power imbalances amongst different credentials. It's very difficult as a non-physician to question a physician's orders. And Dr. Noer is with us this morning. Good morning.
Hi, Shauna. By the way, Angela, Shauna is a plant.
She's a plant?
Correct. Until last week, she and I worked together for St. Charles Hospice, and this is a question which properly should be discussed physician to physician. Unfortunately, social workers, as, quote, safe people, frequently get hit with these scenarios, and this is where I concur with the presenters that all parties really need to be on board and speaking with one another.
That's a good reminder, though. If you are a part of the team and you are trying to advocate for your patient, one of the first things you need to do is to get a hold of that doc and let them know that there is something disturbing their patient, and see then if the docs can have that physician to physician consult. We do that through our initiative here locally in Central Oregon. When I'm called in for complex case consults, first thing I ask is, where's your doc? What does he or she have to say about this? And do we need to have a doctor-to-doctor consultation? It's very difficult and uncomfortable for non-physician team members. So, Dr. Noer, you have the next question too. And you had editorial comment regarding slide 26 to see all the medications a patient is actually taking. Nothing beats a home visit and asking the patient. And here's where I'm going to let you fill in the rest of that, Dr. Noer.
Okay, I'll see if I can scroll down to the question, but no, this is one of the things. First of all, I really appreciate the input from clinical pharmacists, and I sometimes throw you all under the proverbial bus when a patient or a family says, but you can't stop that medication, they'll have a heart attack or something similarly horrible. And I'll say, well, the clinical pharmacist for your facility or your health plan or whatever the situation recommends that we discontinue that medication. So I will make the clinical pharmacists the bad guys. Sorry. But no, this is just some background. As I mentioned, until last week, I was actively practicing hospice physician. Prior to that, I was in family medicine practice, and going over the med lists, asking your patient to bring in medications for office visits, and you'll get the grocery bag or the shoe box. You're never quite sure, but for those of us who have been privileged to make home visits, I will actually say, okay, the dining room table is cleaned off. I'm going to sit right here. I want you to bring out everything. Prescription, non-prescription. I don't care if it goes in your mouth, in your nose, in your ears, in your eyes, in your rectum might be a little bit excessive, on your skin. And they'll usually bring out a fair batch, which gets scary. And then I say, is that everything? Well, yeah, those are all the prescription medications. I want to see everything that you got over the counter. I want to see everything that your friends or your relatives gave you to try. I want to see your supplements. How about health foods? And now that cannabinoids are legal in Oregon, both medicinally and recreationally, I want to see all that stuff because, as your presenters will tell you, all of those things have potential drug-drug interactions, which people don't take into account when you ask them, I want to see all your medications. They immediately go mentally to, okay, oral and prescribed.
That's a good point, Dr. Noor. And I'm wondering if our presenting physician, doctors can address that piece around cannabinoids and what is the latest research out there? What are our pharmacists being taught or told how to handle cannabinoids and potential interactions, adverse interactions? Is that being addressed to the extent that you feel it needs to be?
So that is a really good question. And Elizabeth may have more knowledge on this than I do, but my understanding is that there's a great lack of studies and evidence for drug cannabinoid interactions, since it's still so tightly regulated federally. I feel like there's just really big gaps in our knowledge and the level of evidence we have for that. Elizabeth, is there anything you would like to add or anything you may know about?
I agree with your comments. That is, we just don't have a lot of studies out there. Yeah, so there's a gap. There's a gap.
So once upon a time in Central Oregon, we did have a physician who had actually done a fellowship at UC Davis, I believe, in the use of marijuana or cannabinoids. I'm using layman's terms. And this was probably 4 or 5 years ago. I'm not sure if she's still practicing in the area, but she gave that presentation at one of our local senior centers, which was filled with quite a few consumers, not just folks like me on the professional side of things. And she was slammed with potential new patients. We are finding that more and more of our older adults are going down that route for various and sundry reasons. That has got to be particularly challenging to physicians and pharmacists. Perhaps that is a training that we need to pull together in the future. Would be more than happy to look into that for folks. I want to throw out another question. This one's from Kelly Brashears. She says she's been to a training and received information on pharmacogenetics and testing for medication absorption effect and how a drug works for an individual. The question is, how do you feel about this testing and do you think it could be useful? Doctors.
The testing, and I'll let Charlotte also jump in and add comments. Some drugs, there's some studies on some drugs testing for the pharmacogenetics, but the testing is also not always there's still a lot of unknowns out there. So just very broadly to say, yes, there's pharmacogenetics testing that goes on. And depending on the drug classes, there's some drugs that we really have a lot of studies on, and some other drugs we don't have studies on. so that's a continuing progress.
Yes, I agree. I think that's one of the new frontiers right now. And yeah, that could be a whole presentation unto itself, I feel like.
Well, and we can certainly take any one piece of today's presentation and spin it off into something much more detailed and meaty. Dr. Noer has given you several different questions around several different classes of different drugs. And what I'd like to, I should say medications, pardon me. What I'd like to throw out is one of his questions is regarding slide 61 and the fact that not all antipsychotics are created equal. And we have the opportunity to discuss a little bit more about selecting agents such as olanzapine for diabetics or quetiapine for Parkinsonians. And I think for this group, it would be very useful to spend a little bit of time around dementias, delirium, dementias. We know Alzheimer's makes up 50% plus of the dementias, but then you do have Parkinsonian dementias. Can you speak a little bit about what best practices would be around the antipsychotics and dementias? And Dr. Noer, if you want something specific to Parkinsonian, since you called it out, please add that in. What would be best practice for antipsychotics for folks that are having psychotic breaks and possibly also their dementia patients? We see quetiapine given a lot of times for folks with dementia and behaviors. And what we've heard from prescribing physicians has been that, sometimes you need to start with the question, was this person psychotic to begin with, or is this just dementia? How is it that an antipsychotic is useful for somebody with disruptive dementia behaviors?
And I'm going to say I probably should defer that question to maybe a physician that's in the audience that has that's seeing a lot of patients that have this problem.
Okay, Dr. Noer,
Yeah,
I think that's
Dr. Noer again. Sorry.
No.
Okay.
This is pretty meaty.
Muted here, Angela. This, again, I'm going to declare my bias and background. As a hospice physician, when I'm dealing with somebody with a dementia and an antipsychotic is raised as a possibility, fall risk is often not an issue. These folks have reached the point with their dementia where they're no longer ambulatory. They're no longer even able to get up off the bed. If you have somebody who's earlier in the process of a dementia, then increased stroke risk is definitely something that needs to be acknowledged and needs to be addressed. In the case of somebody with end-stage dementia, there are two considerations to bear in mind. Number one is caregiver burnout. If you have a demented patient that family is trying to care for at home, and because of the psychotic manifestations, things are just getting totally out of hand, you have the discussion about, would an antipsychotic help? Honest answer is maybe, maybe not. The evidence is really pretty squishy. The second point is that as dementias progress to the point where the patient is not only non-ambulatory, but essentially non-expressive, the psychotic manifestations become much less prominent, and you're able to taper down and off the antipsychotics. The strongest evidence for controlling the, and I'm going to use a term that I love to hate, the quote, behaviors, unquote, is supporting the presence of a comforting human. There is nothing, there is no medication that beats a human at the bedside to calm somebody who is going through the agony, both to the patient and the family, of psychotic features.
That's an excellent point. Human contact can do a lot in soothing. So, Dr. Noer, you've done us the favor of owning your bias, and that your particular specialization has centered around end of life. How do we do this, though, with somebody that is very much active and maybe in a memory care facility? We get this all the time. We get folks reach out and say, you know, I've got somebody that has put other residents in the hospital. We're about to do a complex case consult on somebody that has absolutely no warning before he clocks another resident or staff person. He has knocked people unconscious. And then he's the sweetest thing in the blink of an eye. What do you do for that? Is that a place where an antipsychotic could be useful? And maybe hearing from our pharmacists around how often do they see that? Have they seen it be useful, or are there better things that are coming down the pike that hopefully will help us address this?
Oh,
That's all right. Go ahead.
No, you go ahead. I was going to say that is a tough one, especially given warnings around antipsychotics in dementia patients and increased risk of mortality. And I was going to defer that back to Dr. Noer and how that kind of risk-benefit decision usually gets made. Elizabeth, what were you going to say? Oh, you're muted.
Yeah, I'm muted. I was going to say that I do see that we have a comment from a psychiatrist in the audience, and I was just wondering if they can
I'm
comment.
Glad you caught that. I'm glad you caught that, Dr. Jackson. I'm going to ask Kelly. Well, I'm going to ask Dr. Davidson first, if Dr. Davidson would be willing to come on into the discussion. I think that is another piece to this that needs to be added in. I mean, we could talk about this till the cows come home, but I want to give it its due. And if we have a psychiatrist who's willing to weigh in about differential diagnosis, psychosis, dementia, delirium, what are you dealing with? Naming the beast first so that you know what you're dealing with. I think that would be wonderful. Dr. Davidson, could you?
Can you hear me?
Ah, there we go. Thank you.
Great. I don't know if I can turn on the camera.
Totally up to you.
Doesn't matter.
We can hear you. We're good.
So in the prescribing cascade, in particular, in cases where the psychotic, or I'll just say the adverse behavior, clocking the staff or caregivers, or sundowning that gets pretty extreme, I always look first for, you could call it intoxication or you could call it delirium, but a combination adverse effect, oftentimes it's anticholinergic pile up. Too many anticholinergics will produce a delirium. And there's a tendency to overdiagnose psychosis, in my experience, and underdiagnose deliriums. And delirium is one of the least understood neurological phenomena that we face. It is, because usually when you have a diagnosis, you have a common etiology and a common prognosis and pathophysiology. In delirium, some of them are pretty obvious, with a single molecule causing delirium, with ammonia, for example. But when it comes to the combination of a brain that's experienced significant insult and trauma, either with traumatic brain injury or through progressive dementias, delirium and psychosis and the base symptoms of the dementia all seem to get real close together. And so the therapeutic index of drugs that used to seem pretty wide suddenly get pretty narrow. And you see this, for example, a small dose of an opiate can produce a delirium, whereas in other people, that would produce no effect at all. So to distinguish between the two, basically I have a chart when I teach for characteristics of psychosis. Psychosis tends to be far more stable. Obviously dementia symptoms are rated on scales, and delirium's most distinguishing characteristic, in my experience, is that it comes and goes, it waxes and wanes, and often precipitously. Delirium is often misunderstood as lingering because a person looks quote unquote completely crazy when one examiner is there, and then in a different situation, minutes or hours later, they're fully oriented in all spheres and so on. So, but the sensorium tends to fluctuate much more in delirium and much more unpredictably than cognitive deficits or sensorium or perceptual disturbances in psychosis. So that's the shortest thing. I don't want to go on and on this, but I appreciate the opportunity to bring it up, because so often what this webinar is about produces things that look like psychosis that are actually deliriums or intoxications.
It's a very good point, Dr. Davidson. Thank you for chiming in. And again, we've had whole 3-hour, 4-hour trainings around delirium versus dementia versus psychosis. I think there's just too much that goes into that to actually answer that question. There is no one simple answer to that question about using antipsychotics with folks that are having, that are also concurrently demented. It's just there's so many factors that play into that. Unless somebody wants to speak up and say, I'm absolutely against it. And we are happy to hear that point of view as well. And also what might make you, work from that perspective. So I want to give folks a chance to chime in, and Drs. Soderberg and Jackson to respond to Dr. Davidson. And I will be screening for more questions as you all are doing that.
Yeah, I think that was some really great discourse. It's so hard to untangle all of these different aspects. And like he pointed out, anticholinergic toxicities kind of fit right in there and are right up in that whole tangled set of factors. So that was a really great call out.
Yeah, agree. Totally agree. Yeah, that was a great comment. Really appreciate it.
Definitely. And I'm going to call out another participant that I've noticed we have in the office. Did I say office? Well, I guess it depends where you're sitting. Tim Malone. who is a Gero consultant, who has a lot of experience of working with older adults who might have comorbidities and dealing with many of these same issues. When do you pull out an antipsychotic? Do you pull out an antipsychotic? Tim, give a shout out if you're willing to join the conversation for the next couple of minutes. There's nothing that says we have to go all the way till noon, and I don't want people to feel like we're holding them hostage, but if we have a few more minutes that we could have some more of this robust conversation, I would certainly enjoy having some of your insights and experiences to add to the discussion. So Tim, if you are there we go.
I'm here. Can you hear me?
Yep, you're good.
Okay. Well, yeah, I'm happy to. I'm really liking what the doctors here are saying. All really good stuff. Yeah, I'm frequently placed in this position of between caregivers at various kinds of facilities and the doctors, usually the primary care doctors, who are prescribing behavioral medications, or the staff is wanting them to. And so, yeah, that's a tough question, when to either bring up, let's try an antipsychotic, or, equally also, I'm often saying, hey, let's deprescribe here. You're, probably over medicating already. But, it's more than just looking at this patient. What are they doing, that is provoking, what behaviors are provoking, this desire for, behavioral medications.
Tim, you're fading out. Hey, Tim.
Yes.
There you go. There
Are you
you
still
go.
hearing me?
Yep.
Okay. And so, there's a lot of reasons, what might provoke the behavior. So you want to really look at all those and get the reasons why. Can be medications, can be the environment, could be, some other residents agitating them that we could deal with that. So you got to get rid of all this other stuff first before you really say, okay, let's try an antipsychotic. But also within that, the answer to that question is, what is the impact on other residents? Is the person, assaulting other residents? If all they're doing is just kind of walking around waving their hands wildly, well, I'm not really a fan of, calming them down with an antipsychotic at that point. But, what's the impact on the staff? And that's an important question. We don't really like to ask that, but I do all the time, because the staff are often not able to give the time necessary. I mean, earlier it was said, yeah, I agreed 110%. Best case scenario, sit down with this person, and give some human contact. Staff is often absolutely not in a position to do that for a variety of reasons, some good, some bad. And so while they do often do that, if it doesn't have a really fast effect, positive effect, they give up on it. And, and they want to get the drugs pretty fast. And so one of the benefits of medicating someone is actually the staff's ability then to give proper attention to other residents. So there's a balance here in trying to do what's best for this individual, as well as balancing, their treatment throughout the impact on other residents and the facility at large, and staff and family too, of course.
Tim, let me.
So it's not a simple question. Yeah, they're agitated, they're hurting somebody else. Yeah, let's give them some Seroquel. It really is much more complex.
And thank you. Those are all valid. And I just, you've raised something that occurred to me. We have had instances where facility docs are frustrated and they just start throwing everything, including the kitchen sink, at this person, where they're making changes so quick to medications of, well, let's increase it. It's been 3 days and we haven't gotten the results we want. Or let's just pull it and put something else in instead. And as pharmacists, is there some sort of hard and fast rule when you are going to make medication changes? And I know we talked about half-lives of certain meds earlier. How fast can you do this, knowing that, you've got somebody whose system is already being overloaded. How fast can you theoretically make changes on this kind of a level and still be safe? What's the first step?
That's a good call out, Angela. Some drugs you would not be able to withdraw cold turkey. Some of them you have to be withdrawn slowly. And there are some drugs that you can just withdraw. You remember the scenario that I gave you with a patient, AA, who was given amlodipine and then had edema. Those are some types of drugs that you can withdraw right away. But there's some other drugs, if patient has been on, let's say they're on an opioid, sometimes you have to taper them slowly. So it's a judgment call and making sure that you don't compromise the patient. You're trying to help the patient, but then again, you're not trying to create other problems by removing drugs removing drugs abruptly that's gonna cause other effects. So it's all, it depends on the drugs that are on board. It depends on the patient. There's a lot of factors that have to be taken into account. So yeah, case by case basis.
I would say that also applies to adding new drugs or trialing new drugs. Some of these drugs we talked about, like SSRIs, it's going to be more on the order of weeks before you can see full therapeutic effects. And it might also require cross titration of different medications off of one and onto another. So that was a really great call out, Angela, about making changes too quickly. And then you end up with kind of a juggling act. And you're unsure of what is causing adverse effects and which medications are actually benefiting the patient.
Because as Tim alluded to it, oftentimes you get these crisis calls from facilities that say, do something now, just knock them out. Which, okay, we hear the cry for help, but we have ethics involved, plus we've got good medication management practices that you may not be able to just snow somebody under while everybody takes a breath. And yet...
Well, Angela, these things are dependent on the individual facility.
True.
And, and the nurses and administration staff that are kind of running the show there. And unfortunately, they change frequently. And, you used the phrase earlier, facility docs. That I would think that would be an incredible improvement in care facilities if each facility actually had a designated doctor that they could go to. Certainly if a person loses or arrives without a primary care doctor, but someone who really has a feel for the facility, for the nurses that are involved, and for how things are going there, that they could be go to, as opposed to a primary care doctor who may not even have seen this client face to face for 2 or 3 years, because it's not really useful to take them to their office. So yeah, I'd like to advocate for that. Let's do something to create actual designated facility doctors who want to do that. Nursing homes have a doctor like that, but the memory care, assisted living, they do not. And most people don't go to nursing homes anymore like they used to years ago.
And those are all great points. It would be great if every facility had full-time medical on board, on staff in the facility, officing there. I think that would help a lot with some of these issues, especially Maria Aranda writes in that pain is often not treated properly, and that greatly affects the dementia patient as well. At one point, I'm going to have our pharmacist back to talk to us about the phenomenon of that pendulum swing that goes from we have to medicate everything, all pain must be controlled, to nope, you're at risk for addiction, so grin and bear it. And where do we find the happy medium, especially with our opioid crisis? And everybody, I was speaking pretty boldly there. Most of our professionals know that opioids and geriatric patients are a bad mix, but sometimes, you know, there's just no help for it. So at some point, I want us to be able to spend some time, do a deep dive on the opioid crisis and the older adult. I know that Dr. Jackson has presented on that in our own area last year. As a matter of fact, I'm really bummed I missed that. So for those of you that are wondering, yes, we are recording, and yes, we will make the recording available. Nazrin, who was out making dinner, good for you. That's good self-care. We applaud you for doing that. You will get all caught up. We only have a couple more minutes left. And I want to respect everybody's time because we could study the lint in our navels for hours on these topics. But you all have given us great feedback, great questions, for grist for the mill. I've got some ideas for our panelists to bring them back. We might even do a panel presentation. Tim, we might bring you on to be part of that discussion around, you know, real life experience when you're out in the field and you've got desperate people that want answers and they want them now. And then that leads into our issue with how do team members work with physicians? And then what is the role of the pharmacist? What is the role of our pharmacists, both in just in our everyday world? When I go to Walgreens, you know, do I trust that my pharmacist really does know the Gero side of things? And if I don't, then I guess that puts me back at the doc's office. So we've got lots to unpack here, folks, and we're not going to be able to do it today. So I want to thank everybody, most especially our physicians, our pharmacists. Tim, thank you for adding to the discussion. All of you that wrote in comments and questions, that's what makes these trainings so effective, is when we can get input and have dialogue. I think this was a fantastic experience. I really appreciate our folks that have been with us from the first moment on. And don't worry if you guys had to float in and out, you've got a recording to fall back on. Folks, we're going to cut you loose, and know that if you aren't on our regular mailing list, reach out to me or to Kelly, ask us to put you on the list for future training opportunities. And if you found your way here by accident, good for you. We're thrilled that you took a risk and decided to give us a chance. We hope we met the mark, and I feel confident that our participants got some good, useful info today. Let's call it. Thanks, everybody. We will see you when we see you. And until then, be safe and be well. Bye-bye.
Thank you. Thank you for having us.
Thank you for this opportunity to talk. Have a good day.